broadcast, and we're delighted to be able to bring this topic to you today, never events for hospital care in Canada. So it's great that we have this topic. It's very topical, and I think that it's probably at the top of mind of most people who work in patient safety and risk agenda. So never events for hospital care in Canada. Patients rightfully expect safe care when they come to hospitals, and healthcare providers work to provide safe care to those patients. Unfortunately, events that harm patients do occur while care is being provided or as a result of that care itself. Many of these events that cause harm are preventable using current knowledge and best practices. Never events are patient safety incidents that result in serious patient harm or death and are preventable using organizational checks and balances. The Health Quality Ontario and the Canadian Patient Safety Institute, in collaboration with an action team from the National Patient Safety Consortium, has sought consensus on the top 10 priorities for Canada's never events in healthcare. The report is now available, and it's Never Events in Hospital Care in Canada, and Lisa will create a link to that when it goes up on the CAN network. To create the report, the group of healthcare quality organizations and experts from across Canada, known as the Never Events Action Team, researched, surveyed, and consulted with providers, patients, and the public, and then made recommendations for this list that we're going to be overviewing today. So we're fortunate enough to have with us two of those members today. Angus Steele is the Senior Advisor for Special Projects at Health Quality Ontario, the Provincial Advisor on Quality of Healthcare, and through the National Patient Safety Consortium, Angus led the Pan-Canadian partnership of organizations that developed and launched the list of the 15 hospital never events for Canada. He has over 10 years experience in healthcare reform in Ontario, Manitoba, and at the World Health Organization in Geneva. Hannah Lake is the Patient Safety Improvement Lead at the Canadian Patient Safety Institute, with a main focus on providing project management support for the National Patient Safety Consortium. She previously managed the research portfolio at the Canadian Patient Safety Institute and has also worked at Health Canada's Products and Food branch, where she was involved in the consultation planning for the Western region. At Alberta Health Services, she's worked with the clinical quality metrics team to coordinate a quality improvement program. And Hannah's passion is healthcare improvement. So please welcome Hannah and Angus, and Lisa will certainly run poll questions throughout, and she will give you the directions as to how you answer the polls. So I'm turning it over to Hannah and Angus.
Great.
Hey,
Thank you so much.
hi everyone. I'll just say hi. This is Angus here. We're really, I think I'll speak for both Hannah and I when I say we're really grateful for this venue. It's really important for us to get the word out of this work, and also to hear back from people that will ultimately be using it. So we're very happy to be here, and maybe I'll turn over to Hannah just to start us off.
Great, thank you, and thank you, Lisa and Darlene, for that introduction. And yes, very pleased to be on this call today and sharing this this initiative with everyone on the line. So I'll just get started and just mention a few words about the Canadian Patient Safety Institute, just in case people aren't familiar with the organization. So on the next slide, we have that Canadian Patient Safety Institute was established by Health Canada in 2003 to work with governments, health organizations, leaders, and healthcare providers to inspire extraordinary improvement in patient safety and quality. And in our current strategic plan, our goal is to have a national integrated patient safety strategy for the country. Now, how did we do this? So on the next slide, we pulled together, as Darlene referred to, a National Patient Safety Consortium. And that was back in January 2014. It was a meeting held in Toronto to develop this National Integrated Patient Safety Strategy. There was more than 40 organizations that were represented, including national patient safety and quality organizations, provincial and territorial patient safety councils and government representatives, as well as patient groups. And we heard very strongly that we did not need a strategy or a framework that would sit on a shelf. What we really needed was an action and an action plan. So through this consortium, we started to develop an action plan. And these are primarily both based in 4 areas. And they're depicted there in that figure on the right side of the screen. And that is in surgical care safety, medication safety, home care safety, and infection prevention and control. There was also a meeting held on patient safety education, and this was over the year of 2014 and early 2015. So the overarching theme thus far from the consortium meetings and subsequent meetings was that now is the time for action, with national, provincial, territorial, and professional and patient groups agreeing to take a joint leadership role in advancing patient safety across this country. And we're very pleased that the Canadian Association of Pediatric Health Centres and Health Quality Ontario have provided great leadership in advancing this. So the purpose of the consortium is to drive a shared action plan for safer healthcare, with the outcome of safer healthcare in Canada. So on the next slide, we have the very specific action on never events. So a key action from these meetings was to research and recommend a list of never events. And through the leadership of Health Quality Ontario, Canadian Patient Safety Institute, and many partners, a team was developed to research and recommend this list. This action team from the National Patient Safety Consortium sought consensus on the top priorities for Canadian never events in healthcare. The current focus is on events that occur while a patient is admitted in a healthcare facility, where the care providers have a high amount of control over care. So that's just an overall highlight, and I'll turn it over to Angus, who will go in more detail about the partners, the methods, and the results of this work.
Great, thanks, Hina. Okay, so the next kind of slides are to walk you through a large part of who we were, what brought this project together, the kind of process we went through, and ultimately the events that we landed on. And then we want to touch a bit on what we see is coming up next for implementation, to support implementation, to support the field, and then some future work as well. So the slide that's up now just shows the partners that were involved in the actual action team. That's the CPSI's language for the groups they pulled together. So we had pretty good representation from a lot of provinces there. You can see Alberta, Manitoba, the Atlantic Collaborative, New Brunswick, BC. We had a patient rep from patient reps from Patients with Patient Safety Canada. It is a really good group. We were able to draw on a large network within each of our provinces. We consulted with other provinces as well, of course, which I'll touch on later. But it was a really engaged group, and we did have actually Doug Cochran is the chair of the BC Patient Safety Quality Council and is a pediatric neurosurgeon, so we had a fair bit of pediatric knowledge as well. So I think we'll do our first poll question now if we could, because I was curious to see who we're actually speaking with today. I know the centers that are involved, but it would be nice to give kind of an idea of what perspective you're coming from. Are you managerial? Are you a provider? A patient family member? I'd just like to get kind of a sense of that. So if you could fill that in, that'd be great. I understand some people in the line are those groups, so maybe just the best representation of who you are.
And if you're an other, maybe just type it into the question pane, and so we can get a bit of an idea of who else is online. I couldn't put all the options in that are possible, so.
I think I gave a lengthy list. I'm sorry.
No, that's okay. There's many possibilities. So.
We did this, I'll touch on this a bit later in the survey we did, but this was actually one of our questions too. We wanted to get a good sense of who the audience we were engaging across the country were. We wanted to make sure we had good representation from patients and family members, of course, frontline providers, as well as people that are responsible for patient safety in their respective areas.
So today we don't actually have any patients or family members on the line today. We have nurses, physicians, manager administrators at 45%, and others we have safety officers, risk management staff, that type of things.
Great. Okay, excellent.
Okay.
Okay, I'll figure out how to close this bar again. Okay, Got it. Okay, so I think we've covered this, but really quickly, I think terminology is really important, and this was our group spent a lot of time on this really at the front end. So never events, it is a bit of an internationally known term now, I think. The UK and the US especially use it. So the way we define it's roughly defined the same way in those jurisdictions, but there was a bit of overlap between definitions that we kind of had to streamline. But for us, we said never events are patient safety incidents that result in serious patient harm or death and are preventable using organizational checks and balances. And that organizational component is really important. Of course, we all know errors happen in healthcare, and it can be one person, but it can be systems. We really wanted to focus on events where we know that we expect human error to happen, but systems should be able to catch these things. There should be checks and balances at many points in interaction and care, which I'm sure you're all very familiar with that philosophy. So we tried to communicate that in the report as best as possible. We also really tried to communicate that it shouldn't imply blame, the word never. It's a strong term, and we know that in many ways that's the power of the term. So there was a bit of debate early on, do we go with something a bit softer like serious reportable events? But I think this kind of work, and I think never events, is powerful in this way, in that it can be a little provocative in just the right ways. But we try to be very clear that this is a call to action. These things will happen, they will continue to happen, but we should be striving for never, and it is possible. It is possible to get there. The next slide shows the criteria we use. So again, I'll get to this in methods, but we did a survey that went out, and this was clearly communicated. These were the type of events we wanted to focus on. But this is also what guided our committee. So we focused on events that were serious. So there's a high risk that the event, if it did occur, would cause harm or death. And we defined harm as, this was a WHO definition, I believe, a significant permanent change in the ability of patients to function as they did before the event. We said never event should be recurring, so it's not a one-off. Basically, it's not a really rare situation. Never events kind of are and should be quite rare, but we don't want it to be a really unique situation that would limit the learnings, I think, of patient safety. We wanted events that were identifiable, so can be easily recognized, clearly defined, and not attributable to other causes. So I'll get into this later as well, but there's some events that, you know, it would be hard in an investigation to clearly say what caused that harm. You know, like say sepsis. In some cases, it's hard to know what condition caused it, where the infection was picked up. We wanted to focus on events where there's a clear point of failure in the system, and that can be addressed. And I kind of touched on that, avoidable. So there's an opportunity to actually intervene. This isn't just a risk that will always be a risk in care. So moving on to methods, the approach we took was to use, we call it a modified Delphi approach. So basically we used our committee as kind of the vetting, but at several points tried to pull in a diversity of opinion as much as possible, and then bring that back to the committee and go through. So we started by scanning other work in never events, but also serious reportable events in other jurisdictions. The UK and the NHS in particular is quite strong in never events, and the US really started it and has quite a good history. The US, as in Canada, the US is quite state-driven, of course. Some states really have run with the never events, some not so much. Minnesota in particular was one of the really forward-looking states that has quite a strong and robust reporting system and tracking, so that we looked at that as well and looked at some of the data from that. We consulted quite a bit with subject matter experts as we went along, stakeholders and patients. As we became more and more clear on what the events would be, our consultation became a bit more focused on, you know, specific disease areas. But we also did quite broad consultation at the beginning, so we talked to organizations like Accreditation Canada, some of the health insurers like CMPA and HEROC. Well, for the medication events, we really lent we had a lot of help from the Institute for Safe Medication Practices Canada, so they were quite helpful in guiding us on the pharmaceutical-related events. And then also clinicians, as we went along, we knew it was really important to engage frontline providers in this, especially as we focused on what the true risks are and what can really be done about these things. So we had a lot of really interesting discussions along the way. So we're quite well informed in that regard. So once we had kind of, as a committee, kind of landed on what we think were the big list of events, we put that in a survey and pushed that out across all the provinces and territories through our own networks, as well as the CPSI was really good at having a strong database there. So we canvassed quite widely, tracked who was responding, not anonymized of course, but allowed them to provide rankings on all the events that were proposed, as well as specific comments. So we did get some really helpful comments from the field in that. And then we brought it back and discussed again in our committee, put together what we thought was the best list that we could come up with based on other jurisdictions and through opinions through the survey and consultation, and actually put the draft paper up in the summer for public comment. We felt that was important too, that the survey was kind of a big bucket approach, so we went quite wide, so we wanted people the opportunity to see what we had ultimately decided on and give a chance for them to comment again. And then the report itself was launched, I believe it was mid-September. So I've put up on the screen now the results. So there are 15 events total. And here are the first 7. We cheated a bit because number 7, you can see there are 5 actual events, but we kind of wanted to focus on pharmaceutical. I think we agreed that a lot of the strategies are common across a lot of the pharmaceutical events, so it was okay to lump them together. But let me just quickly walk through. So the first one is surgical, surgery on the wrong body part, patient, or the wrong procedure. Second, wrong tissue biological implant or blood products, so that's a lot of the ABO incompatible transfusions. Number 3, foreign body left in patient following surgery. Number 4 was improperly sterilized instruments and equipment. The 5th is an allergy event, so all of these actually have better descriptions in the report. This is for a PowerPoint. I've gone quite brief with them, but the allergy event was kind of a 2-part one, so it was either a failure to inquire with the patient if they had allergies, also obviously exempting emergency situations when the patient cannot respond. And then the second step was that if an allergy was known, identified to a healthcare provider, it would be an ever event if it was not adhered to and they had delivered a substance to which a known patient allergy was. Number 6 was wrong gas administered to the patient. So number 7, as I said, there's 5 pharma events there. So ISMP Canada was really helpful here. They kind of provided guidance to our committee, and we also got some through the survey and with pharmacists across the country. But they really said that these were the top 5 events that they see through their reporting system, as well as knowing what fit our criteria of never events, so ones that are really actionable and can be prevented. So wrong route chemotherapy, intravenously administered potassium-containing solutions, injection of epinephrine that's intended for topical use only, the wrong concentration of hydromorphones. That is often, I understand that it's often purchased in 10 times quantity, and there's certain uses for that, but often it's not diluted, and that's a serious risk to patient safety. And the final was a neuromuscular blockade without sedation, airway, and ventilation control. Number 8, so we wanted an event that was focused on metabolic disturbances. So we actually the whole purpose of never events is that in time this kind of list can evolve, but we felt that the 2 big ones to focus on right now were hypoglycemia when identified in facility, and this one is specific to neonates hyperbilirubinemia. I'll touch on that one later because that's, I think, probably one that's quite of interest to the group today. Number 9, stage 3 and 4 pressure ulcers following admission. This one we went back and forth on how to best define it. There were some people that were saying we need to be much more aggressive and look at all pressure ulcers, but there's also recognition that patients often are admitted with stage 1 or stage 2 and it quickly progresses to stage 2 or 3. So it is a little more realistic to focus on the ones that are more severe. And that actually aligns with the US, I believe, reports in that way as well. Number 10, we're now getting into kind of the more environmental events. So this one is MRI event, so uncontrolled movement of a magnetic object. Number 11, accidental burn. So accidental is quite deliberate there. Of course, in surgery, there's instances when you could consider that a burn, but it's intended for patient treatment. So that is not included as an ever event, of course. Number 12 was patient elopement. I'm going to talk about patient elopement and patient suicide together the next event. So we went a bit back and forth with this one as well, and we had some really good consultation with mental health hospitals and addictions that were quite instrumental in talking us towards this kind of focusing on patients with the highest level of observation. For suicide particularly, it was a lot of people said that is suicide truly preventable? You know, you can't, if someone is absolutely determined to take their life, can we really say that that is reliably preventable? And we kind of agreed that it's not. But for patients under highest level of observation, it should be. And ultimately, the advice we received back from a lot of mental care providers was that, you know, don't focus on anyone in mental health care, even if they're on a secure ward. Giving patients freedom is a vital part of their rehabilitation. So really focus on the ones when the suicide risk is imminent and known and they're under the highest level of observation. So they felt in that situation that suicide should be preventable if the protocols are adhered to. So I think the description of the never event specifically touches on not following protocols, and that's the failure point. Number 14 is also a pediatric focused event, infant abducted or discharged to the wrong person. At some point we were considering going even bigger beyond infants and looking at all patients, but there's some evidence that, you know, sorry, not for abduction, I'm talking about patient elopement again. No, we decided instead of focusing on all of them, we'll focus on those at the highest risk of observation, highest level of observation, as well as infants. And then, oops, skipped ahead there. Number 15, this was one that Doug Cochran was particularly pushed for, was to have an ever event on patient transport. So we went back and forth on this one a bit too, but we ultimately decided to focus on a specific section of patients, so frail patients and those with dementia, and making sure that when they're transported home or to another ward that they're left in a safe environment. This is really to address some events that have happened in the past when patients are left at home and their family don't actually know they've been left at home and they have dementia or they're quite frail and at real risk. So I thought I'd get a bit into pediatric events specifically. I've kind of touched on a bit of it. I think it's fair to say that all the events, with the exception of that last transport, because we specifically focus in on frail elderly and patients with dementia, but all the other ones, and correct me if I'm wrong later, but I think all the surgical events certainly apply. Drug events, as far as I know, can occur in pediatrics as well. So I think they all do apply. As I touched on, the metabolic disturbances and infant discharge to the wrong person are two that are quite specific. The hyperbilirubinemia, I'm still learning to say that one, was a really quite interesting debate. We came close to dropping this one at one point because some of the advice we got from pediatricians was they were quite concerned about the attribution in this one, being that a lot of neonates develop hyperbilirubinemia. It won't be picked up until after discharge, so when they're in the community. So there's some concern that, will you really know if these patients are out there with it? Will it be more in general practice? But ultimately, we kind of decided, let's keep it in. They should be picked up when they're in hospital. If not, there should be a catch in the community or when they receive well baby visits. But we felt that this is one that should be included for now. Sorry, I lost my train of thought here. I had another point there in pediatric events. I'll come back to that. So I think, so now that we have the list of never events, I think it's really important to just acknowledge that we don't expect a list will solve anything on its own. I think that would be incredibly naive to think that we can just put it out there and that's that. So we really feel that deliberate steps need to be made now to spread awareness of it, to harness the knowledge in hospitals that can actually push for these things to be prevented and not occur in the future. Our report touches on it a bit. We didn't want to include too much. We didn't want it to be a quality improvement report. I think the power of the report now is to really put a stake in the ground saying these are things that we all agree on can be prevented and should be prevented. So we wanted that to be the focus of the report. But we also just didn't want to declare they won't happen and therefore won't ever. So we did touch a bit on, in the back of the report, on strategies around culture within facilities and environments, clinical teams that are really important for patient safety. We touched on reporting and learning. There's certainly some knowledge now about how best to track these things. I think across the country people are more focused on the structured quality improvement methodologies, so we kind of want to acknowledge that that's a key strategy to address. Looking at identification of opportunities for important, and really that philosophy of continuous improvement supported by measurement and evaluation. So I also kind of want to acknowledge that never events isn't and shouldn't be the only show in town. It's not the only focus of patient safety. There's a lot, of course, you'll all know in your own facilities, I'm sure, of local quality improvement, and also nationally and provincially there's a lot of other strategies, competing strategies if you like, for patient safety. So NISQIP is an interesting one for surgery. Canadian Institute for Health Information is developing a patient safety indicator, which you might also be familiar with. So everything has its own, focus within patient safety, and I think there was some discussion that, is there a risk of putting another set of priorities out there? Possibly. I think it's important that people choose what they want to focus on, but I think we ultimately said the real power of never events is that they are very specific. They cause serious harm when they happen, and they are preventable. I think there's been some comments that some of the other patient safety focuses, if you look at mortality or postpartum mortality, for example, it's hard to attribute that to anything specific. It's hard to know exactly what the action points are for clinicians, for the hospital, for teams. So it's not to say that you shouldn't focus on that. Of course you should, and errors in diagnosis, for example. But I think Never Events offers that opportunity to be quite specific and targeted in quality improvement. So we felt we'll put it out there and give organizations and jurisdictions the choice of what they focus on. I also wanted to acknowledge there are weaknesses to the Never Events approach. They are quite rare. Some people are saying these aren't the biggest risks to patient safety. Patients are much more likely to be harmed by other things that aren't on the list, and that's quite possibly true. But like I said, I think it's important to focus on ones that are quite preventable as well. There was some comment I heard from the UK. They said, I don't think we're at this point yet, but certainly not in Canada, but they felt, I think, as Never Events go on, there is quite a good body of knowledge now on what they should do to prevent it, and the culture within a lot of NHS facilities is much better around these things. They still occur, of course, so I don't think it's fair to say that all the knowledge has been picked up as well. But that's a risk maybe down the line that, we'll all become so good at preventing it, but that wouldn't be such a bad problem to have. And then that last point is just kind of acknowledging there's two competing philosophies, and I think there's no answer to this. Everyone's going to have their own opinion on what we should do. Some people are looking for priorities. They've called on people across the country to provide a focus on patient safety and kind of drive that leadership. And then there's the risk, of course, that there are too many frameworks out there, and that if you're focusing on everything, you're focusing on nothing. So I think, it's important to be mindful of these things as we push forward with patient safety. So just looking forward, kind of what we're thinking next, I I think we still have a lot of work to do in creating awareness that this work is out there. When we launched, we got I think we were quite pleased with the amount of media pickup. So it was picked up by a lot of national outlets. It was a top story on CBC for quite a long time. So it got out there, but that's not enough. That doesn't mean that everyone knows of it. We've asked all our partners across the country to keep kind of thinking of this work as they go forward with their local quality improvement. The CPSI was really good at providing the work to all deputy ministers across the country. But I think we can still do a lot more. There's opportunities like this today, for example. We're really keen to get the message out there. But then we also need to think about how do we actually support, it's not enough to just put out the priorities. I think we need to think about how care providers can be assisted, and there's a lot of learnings to be shared. I'm sure, as you all know, within any center, it's hard to know what's going on. You're all busy people, and it's difficult to know what learnings have been captured across the country. So I think it's kind of on organizations like mine and Hina's to provide that and to share that knowledge. So we have a call as well coming up in December with all the partners again. We're so focused on getting this out that was the main push. But now I think we've had time to let the dust settle and think about what can we do next, how can we push awareness, and how can we think about more supports. So I'll let Hina jump in here. She had a couple points there on specific actions that CPSI are taking.
Great, thanks. So we did want to mention 2 specific resources that are now available to everyone on the line. So, and some of them you may be familiar with this already, but the first one is the Incident Management Toolkit, and that's available from the Canadian Patient Safety Institute website. It's designed to help healthcare organizations to prevent patient safety incidents and minimize harm when they do occur. So the toolkit does have practical strategies and resources related to patient safety and incident management. It is evidence-based. It's based on expert advice, regularly updated, and it's a toolkit for people that are responsible for managing patient safety, quality improvement, risk management, and staff trainings, which I know sounds like a lot of people on the line fit into that. The content was developed by the Canadian Patient Safety Institute with a writer, but we did also have expert faculty as well as patient and family representatives, and is based on the former Canadian Incident Analysis Framework. There was also stakeholders involved through focus groups and evidence included from peer-reviewed journals and publicly available information. So that's available off our website. And the second resource we wanted to mention is Global Patient Safety Alerts. That was launched in 2011 with the support of the World Health Organization by the Canadian Patient Safety Institute. This again is a web-based resource, and it features a collection of patient safety alerts, advisories, and recommendations for healthcare providers and organizations. Now what this does, it collects, reviews, and indexes information from contributing organizations from across our country in different jurisdictions as well as the world. So those who are willing to share what they have learned from patient safety incidents. Now, as this relates to never events, what we're currently doing is taking a look at the data that's available in the Global Patient Safety Alert and doing an analysis and a review, and taking a look at the relevance and impact for the 50 never events which Angus went through. And we're going to look to create supporting documents for organizations and summarizing the strong recommendations on what can be done when these never events do occur. And we're looking to have that probably by next year. So that's something to stay tuned in, and we can provide that to this group as well.
Great, thanks, Hina.
Yep.
So I think this is our last slide, and then we'll get to discussion and questions. Just want to touch on what's ahead. We talked about supports there, but there's also some future work that was identified. One was when we started on all never events, it was going to be all of healthcare. It quickly became apparent that we needed a bit more focus on that. Preventing events and patient safety risks are very different in the community than they are in the hospital. one of the main reasons I think for that is that the locus of control is a lot less in the community. You know, drug administration, for example, that's largely on the patient, and certainly there's things we can do to improve safety with patients and in the community, but it's not quite the same focus, and I certainly wouldn't call them never events. You know, I don't think the locus of control is high enough to say they're reliably preventable. There's a lot of work we can do to lower the incident and the risk, of course. So we had a representation from the Royal College of Family Medicine, and he was quite keen on doing a similar work for patient risks in the community, so in primary and ambulatory care. So that's work that should start moving ahead fairly soon. I don't think it'll be called never events, of course, for the reasons I just outlined. Always events is the second point. So that was always a point of focus, and I think, you know, never events, as I said, risk sound quite negative, you know. So I think on one hand, always events is kind of the positive counterbalance to it. But really, what that would be focused on is saying what should always be done to improve patient safety. That might be kind of based around the never events. We don't know. It might take on its own thing of just generally what should be done in hospital to improve patient safety, things that should always and reliably be done. So that work will be moving ahead soon as well. And then ultimately, I think never events should continue to evolve. It's not a document. It's not a set of priorities that should stay fixed forever. I think one of the big problems we have is not really having great data on these things. You know, you can pull a bit of it out from things like you know, hospital databases and provincial risk management, critical incident reporting, but I don't think we're quite there. We know exactly what the priorities are. So I think as we become better at that, and maybe as provinces improve their reporting and collection of this information, we'll have more evidence to say what are the real priorities and what truly is preventable. So, and that's what's happened in other jurisdictions. The US has been fairly concrete about theirs, but the UK has taken a very iterative approach, and I think that's to their benefit. Over the years, it's kind of shifted into certain areas and ultimately become a stronger list. So we kind of capitalized on that, of course, and we were late to the game, but we were able to build on that knowledge. So hopefully there's a bit less evolution for us, but you know, I think we should be open-minded that these things can change. So I'd like to get to a bit of discussion and give everyone an opportunity to raise. I've put some questions up there, so just thoughts I thought you might be interested in, but we welcome all questions. So one was just, you know, is this worth advancing? Do you buy into it? Do you think this is a set of priorities that could benefit patient safety? Do you have ideas for promotion and advancement? What supports might be useful and welcomed by hospitals and your staff? And then certainly any pediatric specific concerns or comments. We're also going to do another poll question or two here. Let me just try to open this up. Okay, it's very difficult for me to read.
That's all right, I'll read it out. So,
what do you think?
Yeah. So do you think that a focus on never events, supported by quality advocates and facility leadership, could benefit patient safety? Oh, it cut off in your facility.
Right. So I think we want everyone to be very honest here. We've got thick skin, so don't worry about it. But you know, we've heard some criticism before that, you know, this isn't our priority, and that's fine. But please be very honest about that.
So people are voting, and I think they're thinking about it a bit.
The report on the cover printer. Thank you.
Just give another moment for people.
Sure.
All right, I'm just going to close it now. And so 59% of the people who answered said yes, they think that it could benefit patient safety, and another 29 said somewhat. So I think that's kind of positive. So
That's good to hear. I mean, I probably worded that question. I said could benefit, so I'm sure everyone sees there's potential, but maybe not concretely, but that's fine.
Yeah.
That's good to know that there's some promise in it. I think we had another question, didn't we, that was related to that one.
So it's about what is the biggest obstacle to having for this to have any impact? And we have a few answers there: awareness, culture, skepticism, focus on other improvement priorities, time and effort required. And if you have another thought, please throw that down. We didn't have a, didn't have a spot for others. So again, there's many things that I'm sure you can think of. So, give people another few moments. And as we're doing this as well, if you have any questions or comments, please type them into the question pane, and or any thoughts around you know, some of the other questions that Angus posed. So I'm going to close up this poll now. And so the focus on other improvement priorities seems to be the biggest obstacle identified here. Awareness and culture are sort of, and time and effort required. Yeah. So they're all.
That's not surprising. I think the focus on other improvement priorities in particular, we hear that a lot, and we know there's a lot out there. You know, there's demands within your own facilities and your own care teams of what should be the focus, what you think are the biggest risks, and bigger than patient safety, of course, as well. You know, effectiveness. There's all sorts of priorities. So it's something we have to be very mindful of. I think it's naive to think we should just put this out there and expect everyone to focus on it. So we certainly don't.
I do have a comment here, and maybe a bit of a question. So Trey is saying, thank you for this helpful overview, and I think the list is helpful, and I'm starting to buy in. But we need to ensure it is complementary and does not direct undue attention away from where we may have bigger risks. I think you sort of talked about that. So diagnostic delay, recognition of severity of illness, delay in recognition or treatment of sepsis. So those are some really big, I think more common issues.
It's a very good comment, and I think we would all, the whole team would agree with that, certainly. I think we're trying to, I think we'll be mindful of this too as we promote it, find the right balance there. I think we have to be respectful that there are priorities and just acknowledge that we realize there's a risk too much out there, asking teams to focus on too much. You know, they have a core job to do. Quality improvement is something they should always be mindful of, but it's not a full-time job for them. So yeah, I think we have to strike that balance, but also not be too apologetic. I think if we're too deferential to everything else, it means people will not pay as close attention to it.
Yeah, so I have another comment from Michelle. And the question is, would always events be a category of issues that could be linked to Accreditation Canada ROPs? So instead of starting a new list, so they have the weight for healthcare organizations.
Yeah. No, that's a great comment. We've been in touch. We're in touch with Accreditation Canada on the Never events, and they're extremely helpful. And we've continued to reach out to them. They provided those ROPs quite early on as kind of guidance for generation of ideas around Never events, so they're quite helpful there. But I think you're absolutely right. I think with always events, I don't. It's early. I mean, we haven't even really discussed it yet. But my own bias, I think this one's a lot simpler to align with existing evidence that's out there. You know, in a lot of ways, it's clinical practice guidelines in some cases, but we'll probably focus a bit more on the organization approach to it. So yeah, I think there's a lot out there and a lot to align with it. I don't think it necessarily has to be a standalone thing. This one will be more supportive, I think, than priority setting.
Great. Darlene or Elaine, do you have any comments or thoughts?
Hi, it's Darlene. Thank you so much for that presentation. I just have a couple questions and a couple comments. When I look at the report and the 15 never events that you have listed there, the first 3 aren't prefaced with patient death and or serious harm. But yet in your definition of a never event, you gave that as the definition. Can you comment on the thinking of the wrong surgery, the wrong tissue and biologicals, and the unintended foreign objects, and whether that does indeed imply that it has to create either death or permanent harm? We've had lots of discussion in this province as we look at our serious reportable events of, are they never events in that they should never happen, or are they never events in that they should never happen and have resulted in? And so just a comment about why those 3 aren't prefaced.
Yeah, well, that's a very good observation. I should have probably touched on that. Yeah, this is quite a debate we had within our team. And at the level, the whole philosophy of the project of never events, you know, is a never event something that actually happened, or should we also focus on near misses? You know, those are all important learnings that come from it, certainly. So I think generally we follow the approach for most of the events that there should be a serious patient harm, you know, to focus on the really serious points. So I think maybe a burn is a good example. You know, of course, it would be ideal if patients never encountered burns in any situation when they're admitted, but I think the UK has kind of acknowledged that there's things like, you know, environmental risks like kettles, you know, that can cause scalding, or I think I touched on the example of a surgical burn that's intentional. There might also be an unintentional surgical burn, which I think we should focus on. So we really wanted, in the burn event, we wanted to focus on what are the really ones that are true risks, can be controlled in the hospital environment, and can cause serious harm. So that's why we focused explicitly on patient death or serious harm. And I think there's a number of events that are like that. That's probably most of them are like that. But as you mentioned, in foreign objects, we dropped that. The same with blood products. I think in those instances, we thought, you know, every instance of that has great potential for harm. You know, anything left behind in surgery is a true, clear risk to patient safety. And it's somewhat often hard to attribute the harm down the road if it occurs a lot later and isn't always picked up. So in that case, we felt, you know, there's a reliable body of knowledge around that. It can be truly prevented. There's a lot of strategies for ensuring that foreign bodies aren't left behind. So let's just say all of them, that should never happen anymore. And it's a stretch goal, of course. You know, I think we all know this will continue to happen. There's a lot of data out there that shows this does happen a lot more often than we think, even a lot more often than we know. So yeah, in those situations and events like that, we deliberately choose to be quite broader. And I should mention the foreign object one specifically. You'll see if you read the event in the report, we do kind of acknowledge that we acknowledge in an emergency situation, it's not quite the same. There are instances when, you know, there's a critical surgery that needs to be done, or someone's rushed in to emerge, and it's quite critical, but I think the best practice shows that in that situation, post-operative imaging is ideal to detect if there are foreign objects. So we just kind of put that as a little caveat in that event. Does that answer your question? It was somewhat rambling.
No, it does. I maybe in the next iteration of this, I'd also challenge you to think about that from metal in a magnet perspective. If we only wait until there's serious injury or death as a result of metal in a magnet, we certainly may miss a lot of our opportunities to put preventative actions in place anytime metal gets in a magnet unintentionally, whether it causes harm or not.
Yeah, I think that's a very good comment. I do have this massive database or spreadsheet of kind of a log of our decisions. I can't actually remember why we didn't decide to do for that specific one, why we didn't focus on everything. But I will check that and log it. I think that's a good comment. And I think, I don't know if everyone has my contact information or you can do it. I'm sure we can put that up somehow. But I welcome any very specific comments on events. I'll certainly keep a log of it, and it'll help us in the future.
Perfect. And I just have one other kind of just a little curious question. It doesn't really make a difference, I don't think, but you use the word avoidable versus preventable, and I'm just wondering what your thinking was around that as to why you intentionally used avoidable versus preventable, or do you think they're interchangeable?
You mean in the report or when I was presenting?
Both. In the report, it talks about avoidable and it defines avoidable, but so we normally use preventable, so it's just a quirky point. It probably doesn't make any difference, but I noticed, oh, I wonder why avoidable was used.
Yeah, I don't know if that was deliberate. Off the top of my mind, I think we did use it interchangeably, but perhaps there was a decision point when we used one or the other. I think we did talk about how things are prevented at an organization level using checks and balances, and in many situations they might just be entirely avoidable. You can design out a risk point in care. You obviously can't design out leaving foreign bodies after surgery. You need to put things into, you need to use sponges, but some of the other events, there might be ways to totally design away a solution. I think gas was a pretty good example of that, wrong gas. There's a lot of evidence about using unique connectors for tanks, so that is mostly done in a lot of institutions, but not exclusively apparently. So that's a good way to design out a solution. So whether that's avoidable or preventable, I'm not sure.
So I have one comment here that sort of goes back to your original comment, Darlene. So Trey says that she agrees and that we need to include moderate harm, otherwise people in governance may perceive these are rare freak occurrences.
Yeah. That's a fair point. It was certainly a discussion as we went through of, I think internationally that's kind of how the term never events has been used. That doesn't mean we should necessarily stick with it. I think it's not reliably used in all countries, so there's certainly room for interpretation and for pushing the concept. But yeah, I think we decided a starting point would be serious harm for most, but as we get more data on this and see how often they occur, maybe that is a risk of this, that it's too rare and that we should be focusing on broader harm as well.
It's Elaine. Lisa, can I ask a question at this point?
Certainly.
First of all, thank you to you both for an excellent presentation. I feel that I've learned more about never ever events from your presentation. So thank you again. From a pediatrics, or the last bullet, pediatric specific concerns and comments, obviously this is, and you've alluded to this is an important area for everyone on today's webinar. And I'm just wondering, from, two studies, landmark studies come to mind. One, of course, is Ross, Baker, Peter Norton back in 2004, and then there's been that 10-year review or sort of update that I think just came out. And then there's also the Canadian Pediatric Adverse Event Study, sort of which emulated Dr. Baker's study, but principal author was Anne Matlow and others. CAPHC was involved in that, and I just wonder, in building this, if I know there was many reference points, specifically the Canadian Pediatric Adverse Event Study, was there any sort of research and looking at what that evidence told us and about the current state of adverse events in pediatrics?
Yeah, we certainly did look at literature on patient safety, and that guided a lot of our work, and certainly the people that were involved in the action team, this is their full-time job of knowing that evidence base. So certainly people had that awareness. I have to confess, I don't think we specifically focused on pediatrics. we were deliberately taking a broader approach for this. But, you know, we certainly did look at a lot of the international evidence on the frequency. What are the biggest risks? What data do we have available? What do we know is preventable in certain frameworks for identifying what are the big pushes in patient safety? So there was that push, but no, I can't say we specifically focus on the pediatric ones. But perhaps that is future work. You know, I'm not.
That's what I was wondering. Is there an opportunity going forward?
I don't think I'd be a huge fan of having, you know, never event lists for every domain of medicine. Pediatrics is so big, of course, that maybe it could deserve its own one. It's not like a, you know, a subspecialty is different. If you had 20 never event lists, I think there'd be some detriment in that. There'd be some benefit in that, you know, a specific unit or team could focus on that, but to the detriment of a wider, you know, organizational focus on patient safety. Which I think there's an argument for. But even if there was just one list for hospital never events, looking at other sources of evidence that are specific, say, to pediatrics would help us, you know, think in future of what to prioritize. So I think that certainly would be useful to do in the future.
I appreciate that, and I just wonder if there's anyone else, Darlene, your thoughts, or Lisa, I just wonder if there's any other comments out there.
I would agree. I think that there may be some unique things that we should be focusing in on and looking at, and you know, I think the Elaine, as you mentioned, the pediatric trigger tool, which, you know, certainly we were a part of as well, and the CPAES study. You know, might be a good start to take a look at some of what we learned there. And that's why I picked up the word actually, you know, avoidable, because in that study we were so intentional in using preventable harm.
And that's actually what triggered me to think about what I've just brought forward, Darlene. Yeah.
This is Lisa. We don't have any more comments at this time from our questions from the audience, and I think we're at the top of our hour here. So I think that, would you like me to put your contact information with the recording?
Yeah, please do. I can just say it as well if people have pens and paper. We'll go old school. So it's my name, Angus.Steele, Steele with an E, at hqontario.ca. But yeah, certainly welcome any comments and suggestions. It would be great.
And maybe I'll put these questions and suggestions that you have on your slide here. Maybe I'll pop them up into the Knowledge Exchange Network, and maybe that might elicit some conversation or comments as well.
Yeah, great. Please do.
So back to
that's on the last slide here. There's the links to the resources that are currently available in case people do want to take a look at that. Great.
Put that up. There it is.
Thank you.
Perfect. So without delaying further, I think I will bring the CAPHC collaborative call to a close. And thank you both again, both Angus Steele and Hannah Lake, for the wonderful presentation that you've done this morning, and the contact information and the links will be included up on the Knowledge Exchange Network. And I just want to remind everyone on the phone that we do meet at the same time on the fourth Friday of every month. However, in December, our next Patient Safety Collaborative call will be on the 18th, given the holidays that we have. And the session will be brought to us with our three speakers being Dr. Mike Kahn, Dr. Trey Coffey, and Dr. Andrew Link. So I hope everyone online today can join us for that presentation. And as always, if you have any suggestions for presentations or anything you'd like the Patient Safety Collaborative to consider or bring forward, please send that information along to Lisa Stromquist, and we'd be happy to look into it and see what we can do about bringing it to you. And just a reminder to watch for the CAPHC Presents newsletter. It provides information on all of the webinar presentations and where you can find everything in the past that has been archived. So please pay attention to that. And we'll hopefully talk to everybody on the line on December the 18th at the same time as the call today. So bye, everyone.
Bye. Thanks very much.
Bye. Thank you. Bye-bye.
Bye-bye.
Thank you.